We wouldn't.
Well, good morning, everyone. We'll go ahead and get started here.
Not the same as you and me.
Welcome to this morning's grand rounds. As we get started here, we do have a number of features we would like to feature, a number of studies we would like to feature this morning. But first of all, I do want to say thank you to all of you for your incredible support. We continue to lead Intra-Illuminate, one patient away from leading in Summit, our 10-9 study. And we have leadership in many other studies, and it's really with the incredible support of the foundation, the staff, the practice, and all of our colleagues and all of you for supporting us in that. So I want to thank you all for that to start. The first study that we're going to feature this morning is a repair MR study. This is a study of severe MR in which patients are randomized between MitraClip and mitral valve surgery. And the endpoints are, as you can see here, and our research coordinator is Jane Fox. And you can reach Jane or me for questions about patients with severe MR for this study. The second study is Half Moon, and this is an interesting study. I don't have a video of the device, but it's a transcatheter repair device in which there's a posterior aspect that functions as a member against which anterior leaflet opposes. And it reduces MR. And Sarah Olson is the research coordinator for this. You can reach her or me for this study. And the final study is TAVR Unload, and this is a study of moderate AS with reduced LV function. And this is a randomized between TAVR versus guideline-directed medical therapy. And Jenny Wen is the research coordinator for this study. You can reach her or Santi, who serves as our local PI and is in charge of our patients with moderate AS. So with that, we will turn to our presentation this morning, and we have the pleasure of introducing Dr. Vinayak Bapat. If you haven't met Vinny yet, you will easily see that he is a wonderful, compassionate clinician and person who initially was born in Mumbai and trained in London and Toronto and established his international reputation at Guy's St. Thomas. He has served as a mentor to hundreds of surgeons, students, trainees, and even cardiologists as well, including myself. And he really has established an international reputation as being a preeminent valve surgeon. If anyone in the valve space would know that every valve technology at some stage of its development or even in commercialization passes through Vinny's hands at some point. And so we're really honored to have him here and join us in our practice. And last summer, Vinny joined us as our new chair of cardiac thoracic surgery. And certainly some may ask, well, I often get asked, well, how do you recruit somebody to Minnesota when it's snowing and 16 degrees out? And certainly we have an incredible practice. We have the innovation, we have the culture, we have lots of things here. I don't think he came here to learn TAVR from me, but this is him learning from me in his first case. No, not really. No, we all learned from him. Perhaps it was he wanted to learn a Minnesota pastime while consuming refreshing beverages. I'm not entirely sure. But I know it's been wonderful having him here. And maybe he came to learn how to do this. Not entirely sure, but let's see how he does. Doing okay? I thought he was doing okay. Then he asked me, it's been a wonderful wonderful experience having Vinny here, and I can't thank him enough for being here and being a part of us. And I'd like to welcome him here this morning. Vinny?
So again, thank you very much. You can see my ignorance in many things. And one of the themes of this presentation is to share the journey of TAVR and actually the journey of me personally with TAVR as well. So this is the Star Edward ball and cage mitral mechanical, which has been in this patient for more than 40 odd years. This slide has a significance I'm going to show later. I do work with most of the valve companies, and that has been my passion in a variety of ways, and you will see why as well. Humble beginnings, of course, in Mumbai, coming from a small town, going to Mumbai was a great. This is a very well-known center in India. First heart transplant, snake heart operation, which became later as TMR in myocardial revascularization, and huge collaboration with Rockefeller Foundation in early days. So we had a amazing working animal lab, lot of work on heparin, protamine, and early days of cardioplegia. Did a lot of things. I always enjoyed publications. Curiosity was always there. And the reason for that was very simple. My mentor, Dr. Tendulkar, always read between lines. He never took anything for granted. And he always told us to challenge things, especially those which are embedded in practice. In India, outpatient clinic was amazing. We used to do it twice a week. We used to have more than 250 patients. And you can imagine that most of these patients were young, and most of them received a mechanical valve. So a lot of early work went into understanding valve design, implications, what patients had. The funniest experience I ever had was my first on-call day in Toronto General, and I was doing evening rounds, and one of the things we had to do was prescribe warfarin doses. There was a pharmacist standing. First of all, I didn't even know there was a pharmacist doing round with me. And she said, so should I give 2 milligrams or 3 milligrams? And I said, my dear, you don't get 2 or 3 milligrams, because in India, we only got tablets of 10 milligram and 5. So you cut into half, it became 2.5. And you further cut into half, it became approximately 1. So that's how we used to do it. So I learned a lot in the early days. We used to implant this valve, and I have a dubious distinction actually of implanting the last commercial aortic started whatever in the world. This was in 2013, when a young professor in London who got married, operated by Christian Barnard when she was young for a CMC, then had a mechanical mitral, had a changed that to ball and cage because the bileaflet used to make so much sound that she went crazy. And when she developed aortic rigor, she insisted she wanted Star Edward. And Edwards kindly found the last surviving batch of Star Edward in Hong Kong somewhere, and then shipped it to us, and we did a third re-op. Tilting disc, of course, again, uh, monostrut, I don't know, but I've seen a patient where the strut breaks off and the disc flies, things like that. But Sri Chitra is an Indian company which is now really leading in terms of tilting disc. It's a much cheaper valve, doing really well in India. And Bileaflet valve, of course, St. Jude started in University of Minnesota. Walton Lillehei and his fellow, Dr. Kalke from India, who later became dean of one of the big medical colleges in India. So essentially, I learned a lot of things. And one thing for sure I learned is that ideal processes doesn't exist. And I'm sure in 15 years' time, will be, again, some younger generation will be discussing the same. We have seen polymers coming through and going. We have seen mechanical valves. We have seen newer solutions. But some things have remained constant. And I think this is what I learned working in 3 different continents. I went to Toronto General, extremely busy practice that time. It was the second largest center in the world, China excluded, and maybe Russia as well. And here I learned a lot of new things. I did my fellowship in adult surgery and adult congenital, then moved to Guy's St. Thomas's and worked there till I became attending in 2007. And then the really fun thing started, because all this was happening. We're moving away from rheumatic to degenerative. And in England, there's a lot of immigrant population again. So we again saw a resurgence of rheumatic heart disease. So I really realized that we have to adapt whatever we do to where it goes. TAVR's beginnings were, of course, all of you know, pretty humble, but 2019 changed everything. And in my opinion, actually, it changed the landscape of what we do for valve disease. And options always being challenges. If you have no option, it's easy. And that's what it was before. We were simply deciding between tissue valve and mechanical valves at that point, or not to do surgery or do surgery. But here, it really widened. And this affected all of us. My appointment was actually aortic surgery. That has always been my passion. And I started that, and within 3 months, I was told that, TAVRs included, and Martin Thomas is coming to St. Thomas's, and this is where we entered the TAVR. Today, what we see is SAPIEN 3, but our entry, so to speak, was with the first generation SAPIEN. There were only two sizes that time, 23 and 26. We used to do 2D echo sizing, so you can imagine how primitive it must have been, or how does it feel today. And these were the days of TAVR. This is me giving a CPR, I think, on a patient. And we had embolizations, we had leaks, we had ruptures, arrests on table, we had injuries to mitral valve. You can name a thing. And we used to, go into it with, a worry and a fear that today what is on hold for us. But this was amazing. The cardiology perspective was just, this is just cool. While the surgeons was, are you really serious? Means this was like going nowhere probably. And this is where we entered. Heart team, when Martin Thomas moved, which was just 3 months after me, I had worked under Martin in King's College Hospital as a chief resident, so he knew me pretty well. And he said, we need experienced surgeon and experienced cardiologist. And thankfully, I was the youngest surgeon appointed, just 3 months. All other 5 surgeons were people who taught me. So I was very relaxed that this is definitely not going to be me, and I'm going to watch from, behind lines. But everybody said, I think we should include Vinny. First of all, he's young, and he has a lot of time. He has a lot of energy. And then a perfusionist actually made a comment. And anyway, these patients are not going to survive. So what's the point? Let's just this guy do the thing. So we went to Cardio Skills. This was actually a Boeing a training center. And Edwards used to hire it. And there were 2 rooms where they used to set up this small thing where, we used to put CDs in the computer and show how the case is done. It used to take forever. And we did training, and the thing was 2008, we are going to do 20 cases. And 20 cases was a big deal. This is a very expensive technology, National Health Service. And we were fortunate that our guy St. Thomas's Charity, which is a big charity, probably one of the richest one in the world, said that don't worry, you do 20, and if 20 goes well, we'll fund another 20. So that was the promise. So we started. I was very relaxed. I had a senior surgeon with me, my mentor, Chris. I was like, he's going to do the case. I have to just run the logistics, and I'm going to assist him. In the morning, he called me that, I don't think I'm coming, Vinny. You have to do the case. I said, look, I'll park your car, but please come, because I'm not going to do this case. He said, no, there are some family issues, and I've really decided I'm not going to come. The proctor who was going to come had only done 4 cases. So this is the days when he was more worried when he found out I'm going to do the case. And we had some hilarious conversations later when it went well. The case actually went well. So a week later, we are doing the second case now, and Chris is still not there. He's on holiday, away. And now the proctor gets stuck in the flight. Patient deteriorates. He can't make it to St. Thomas's. We are calling him. And so Martin Thomas said, are you sure you can go ahead? I said, yeah, let's go ahead. And case went well. A month later, Chris turned up, and Edward said, why don't you teach him? And that's how actually my journey started. And they say that ignorance is bliss, and really that was a bliss, because I really didn't know what I'm getting into. This was the changing movement for me. I always loved technology.
As you can see, with rapid pacing, it is very stable from a transapical position. So where you position it is pretty much where it will lie. And that looked very, very good, I have to say, Martin. One of the reasons why I do think that there may be some advantages to the transapical approach. And you've seen an aortic valve replacement in an 88-year-old woman that was performed in 12 minutes. You can't help but be impressed with that work.
So this was following 2 successive cases where patients had actually died on the table. And this case really defined St. Thomas's as a team. And this got us, me at least, introduced to most of the leadership. This was a really good case. We worked as a team. I was actually the only one without a mic. So Marty kindly sent me this video a few days ago. This was a humbling experience, to be honest. This is what I learned. We were very inexperienced. We didn't know what we were doing. This is the case we had implanted a SAPIEN very nicely, but there was a lot of AI. One of the leaflets was not opening. So we tried every trick. We used different catheters to poke open the leaflet. We re-ballooned it. We really tried everything. And eventually we decided, okay, it's a 20,000 pound valve and we have to implant another one. We decided, let's just do it. So Chris was doing the case, I was assisting him. And after this, of course, we had removed the wire. So we rewired it, and we had rewired it 2 or 3 times before. So eventually you can see these are our surgical skills, waving the wand everywhere and hope it goes. And then he started pushing the other one, and he said, there's some problem. I said, Chris, you just have to push hard, trust me. So Chris said, okay. And you will see in a minute what happens. And we all were watching this case, not like, the wire was passed and everybody was chit-chatting. And so it said, okay, I think it's making progress. It looks nice and straight and coaxial. That's a new word I had learned in the lab. There's something called coaxiality. And then the coaxiality led to something extremely interesting. And before we knew, the valve embolized because the wire had gone outside the valve. And then, of course, there was a panic because we didn't know what to do. This had never happened to us before. So first of all, we decided to implant this valve so that patient stabilizes, which was a smart decision. But the issue became is how to manipulate that other valve into the right because it had turned upside down as well. So after many, many things, eventually we got it somewhere in the descending and then we stented it. This was not the first or last time it happened to us. This happened to us a few more times. Root rupture is, of course, dreaded. I'd got my new video camera. We wanted to record a few cases. And we're doing a transfemoral case, porcelain root. And there we go, the root ruptured. Again, that time we didn't know a lot of things. And one of the things we always hesitated at that time was, should we leave the TAVR device behind? Most of the time you open the case, we used to open the aorta, take the TAVR out and do more. So here we were forced to leave it behind. So I had to just take sutures on the right coronary, put a vein graft on the right, and actually we left the TAVR and the patient survived. She had a bit prolonged course, but she survived. So we realized slowly that you need to support complications on FEM-FEM. If you need to open the chest, do minimum and get out because these patients were pretty old patients and very sick patients. But I also learned an important thing. The famous book, Men Are From Mars and Women Are From Venus, and this actually applies to cardiologists and surgeons. This was amazing community. People used to fight showing my complications worse than yours. And coming as a surgeon where we say, I never have complication, this was an eye-opening moment in my career. And I realized that actually you should show complications, you should share because you can only get better with time. And then 3 people really played an important part in my career and my thinking. Martin Thomas, was lead in TAVR. He also started London Valve Meeting, which is the most successful meeting today. He currently works as a VP in Edward Life Sciences. Mike Mack, most of you know, he's a very famous surgeon in Texas. And finally, of course, Marty Leon. So these 3 are still my mentors, and I bounce every new idea or whatever comes in my head to these 3. A lot of innovation followed because Martin Thomas was amazing. He really let us thrive. He said, new ideas are great. We are a small size center compared to Germany. The only way we are going to make impact is we think different. So we started a lot of things, TAO approach, many things, valve in valve, of course, but different valve designs. We had input in every delivery system which we use today. This was just an incredible journey. We also started the concept of TAVR-proof surgery. Means this is, today we are talking of, sequencing and everything else, but all this started there. The transaortic case, the first one again, many years ago, a patient who couldn't have any other approach or any other thing, we decided to go transaortic. This was case number 7, which convinced us actually that this is a good approach. This is a patient with total pneumonectomy. Couldn't do TF, couldn't do subclavian at that point, so we did a transaortic procedure. And this is the time Edwards actually took notice of that approach and said, let's have some conversation around it. One of the best things of all these things is you make a lot of friends. And we had trained South Africa just around 2010, me and Martin Thomas. And then it was our first safari holiday. We are enjoying it. This is in South Africa, Greater Kruger. And then as we come to Cape Town, I get a phone call early in the morning saying, we have a case. And I'm like, who's calling? So they had found out somehow that I'm in South Africa. And I realized that the safari world is well connected. So they found out which hotel we are staying. And then Werklaken, which is again and Tigerberg University, they said, we have a case. She needs a TAVR, but we can't do anything else. So can you please come and help us? So 5 a.m. in the morning, I went there. You can see the Osiris green symbol, and John probably, this was a free version of Osiris, and I had learned how to do a bit of it. So we created this aortic map and said, I think there are soft spots on the aorta we can go through. And Dr. Spencer King actually was a visiting professor that time, and he was the editor of JACC Intervention at that point. He was so impressed because 5 o'clock we started, by 6:30 we had finished. And then I was back in the hotel at 7 with family. And so he invited me to write the article of, myth of porcelain aorta. And this is the article we wrote on how to do aortic calcium mapping. Of course, today we have got very refined ways of doing it, but this is how we started doing, CT analysis of calcium. A transfemoral delivery system, those who have not been exposed to this has been really lucky, I think. This was no nose cone, a large delivery system. We used to have vascular complications, I think, every month. So we were very well trained in handling it. Sometimes, we used to lose, but sometimes, most of the time, we used to win. But we were involved in all these modifications. Me and Martin Thomas spent a lot of time flying to, Irvine, going through different iterations. The engineers used to come back. We used to do bench testing in London, record it, send it to them, etc. And same thing with the transapical system. This system was a really hard system to use for surgeons. Martin always used to say, surgeons can't do this because our hands go together. And we used to push the valve in the ascending. It used to lead to chaos. So I developed a technique called IKEA technique for surgeons. And this became very popular because in IKEA, if you buy furniture, if the nut or bolt doesn't fit, that means you are doing something wrong. It's not that it's not correct. So this is how we started, and we started actually getting better results. But the new generation came. Mark Dedachian was a VP that time, who remains a very close friend. He's retired now. And then, of course, we developed the Certitude system, the sheets, everything. So it was really encouraging. We forget that the TAVR has become successful today. I don't think it's because of the valve. I think it's mainly because of delivery system and the CT imaging and everything. If you give me first generation Sapien valve on this system, you can make it work very well. So I think a lot of new things have happened, but we forget the iterations in delivery systems have been really important. Today, nobody does BAV, but this is where St. Thomas is, that's where it started. We demonstrated that actually you can just put 2 cc's to inflate that balloon. And this is one of the first cases we did. This was a TAO case in St. Thomas's. You can see that just inflating 2 cc to open the valve and pop the valve in, retract the pusher, and then do it. So TCT, we did a live case there, and we used to have piles and piles and piles of balloons because they used to come in the kit. We used to always tell Edwards, take 100 and give 1 valve free. But today, of course, no BAV has become again common, but it took a long time to get there to that point. Expanding indications was again, where I'm leading probably is valve in valve. This became as it was mainly as a distraction. I was so involved in transaortic that it got me crazy at times. I thought, I need something different. I need a hobby, right? So it was photography, valves, etc. And valve in valve was really, really nice. This is 2010. This is our first case in London. And this was quick, no blood loss. Patient did really well. So we started kind of involving ourselves more in that field. But the early results were hit and miss, and a lot of lack of knowledge. Again, this is a new area, of course, and a rapidly evolving field. So this was a chart. It still is with me, but it's not in my office anymore. But it used to be pinned in front of my computer. And everyone used to email me, Vinny, I've got this valve, what is the dimension? And I used to email them, and I'd built like an image library. I used to send them, images. And this was the way most of us used to communicate. So we did the first publication based on that. I said that this is tiring. Surgeons don't know how the valve looks under X-ray. Cardiologists don't know how the valve looks in reality. So this was the basis actually of the first publication. Preceding this, the other publication was in, I think, 1960s or 70s. So you can imagine there was nothing there. So a lot of the authors, by the way, are medical students. So we did the first publication, which is the figures which you see everywhere, probably used in multiple publications, without probably even the knowledge of where they came from. And we realized that there are a lot of valves which look similar. They have some similar properties. This has been exploited in many ways. All this work we did was great. So for example, 2700 can expand, perimount. Of course, that time we didn't know how to fracture, but it can. How to differentiate between perimount and magna. Early days were different. Today, of course, we have become very smart about all this. The second thing we published was very important. We realized that we are using wrong dimensions. The dimensions were given for surgery, not for TAVR. So the first focus came is, we used to think, hold on a minute, this is a 22 size ID, but when I put in a 23 valve, it's not expanding enough. It's actually kind of constricted. So I started measuring, with a Hagar dilator and realized that the dimensions are very different. And the pig valve dimensions are different than pericardial valves. So there's something wrong. I actually traveled with all the Hagar dilators everywhere. I came to Minneapolis to St. Jude. I went to Irvine. I went to Sorin in Italy. We measured all the valves with engineers physically. I used to carry a letter which used to say, this is a medical instrument and not bullets or whatever, because Hagar dilators do look like that. So it was fun. And what we came through, as you all know now, that surgical label size has no meaning. All the dimensions are different. And then we defined what is called as true ID. And we classified the valves in 3 different ways, which remains probably today what we use every day in our practice when we do valve in valve. The ISO standards, which will be introduced this year now, anytime, the publication is already due. They have incorporated True ID as one of the terms now in the ISO standards, and every company will have to give us True ID as well going ahead, which we know already, but legally and etc. they need to do it. So then we realized few other things. People used to say, but I implanted the valve, but I don't get good results. So we realized it has to be ideal implant. Ideal implant is what? Ideal implant is it doesn't either embolize and it gives you least gradients. So again, came with a very common sense algorithm of what is, the ideal implant. Sewing ring of the valve, in my opinion, when I had done the measurements, was the narrowest part. So I said, if we implant like, a few millimeters below that, that should really work. And this was the publication, and this is what we even follow today. But one of the very senior engineers in Medtronic asked me, why do you think sewing ring is the narrowest diameter? And I said, John, actually, you know what? You're right. I know it is, but I don't know how to demonstrate it to you. So we did simple experiments again. We just inflated balloons in each valve, all the valves. And then we found that sewing ring indeed is the narrowest part. So you want to anchor, you can anchor it there. And then it became easy because we could give people where the sewing ring is on fluoro and how do you implant in relation to that sewing ring. And again, this became an important step in valve. London, St. Thomas's, Ross procedure, homographs, we used to have so many coming back and a lot of these patients were sick. So again, this was the largest experience, first presented in 2013 in AATS and then finally published in 2014. I presented this and again, homograph tips and tricks, where it all started in St. Thomas's again. We also realized that, TAVR devices are different. As new TAVR devices are coming through, they look different. So we need to know where the leaflets are, where the bottom is, where the skirt ends. And all these things became really hard to explain anybody in an email. So we had to do something. And as I always very proudly show that I probably wouldn't have come up with the solution, but kids and teenagers have a different outlook in life. Living in Minnesota, this doesn't seem very bad, but in London, this much snow is, my God, this is bad. Means, trust me, 80% hospital staff wouldn't turn up because they can't drive in this snow. So I was feeling miserable, the snow, and she was out, dropped me to school on the way, and I saw this smiley face. So very different approach to life, I thought. She came up with the idea. She said, Dad, you should develop an app. Everybody's using these apps now. And this is the good way to do it. It was on a Christmas day. So we sat next day, and then we went through the chart, and that's how we built the app. The build was very interesting and fun. I'm not going to go through the details, but we had to go through all these challenges because being a very busy surgeon, doing 250 cases, TAVRs, traveling, this was really hard for me to get my head around. And whoever I explained, nobody understood, what are you talking about? Why do we need it? Then finally I emailed Marty Leon, and he replied in like 7 minutes. And he said, Vinny, whatever you need, this is amazing, this is great idea. So then we all started this process. And then finally we got funding from the hospital. And then we, did a lot of, this is all logo work we did. We did it ourselves with me and my daughter. And finally, now what you see is a Osiris reconstruction of a Hancock valve CT. And this is what the aortic valve looks like. And again, it's a very easy flow to follow in the app. A lot of people use it now. And this app generally takes you through the whole procedure. That was the idea. And we saw the benefits of this app. I did a virtual case on Skype in Chile, doing a double valve in valve. Or you're doing a virtual case somewhere else. You could guide people through the app. It was not even this sophisticated that time. It was pretty simple, the first two versions. This gives you a lot of information. And I use this many times when I see my patient. They say, which valve I'm going to have. So I open the app and show them the picture. This is the Inspiris valve you're going to have. They feel connected with it. They know that this is the valve I'm going to get. Oh, there are 3 leaflets, I see. So there's a difference between pig valve and pericardial valve. Simple things. This is what I use it many times actually. So this flow was very, very good. And as you see, there are a lot of informational things as well, additional information section. A lot of work has gone in, and friends all over the world have contributed to this. This is not my contribution, actually, I would say, but this is a contribution from many, many people in the world who freely shared the information so that we can share it across with each other. Mitral valve in valve app was great. I was stuck in Japan for 7 days. We did this in 14 days, flat out. And mitral valve was different. You can see here, amazing mitral valve in valve case done. And then a few minutes later, this was embolized. This was surprising. Then we realized that they do actually embolize even after a few months. And this is where, again, the bench testing with Edwards engineers and in St. Thomas's, and then publication followed. And this is why we advise conical deployment. And the conical deployment came from that work. Mitral valve in the ring is very complicated, and we just heard a presentation last Thursday, but this work has been going for nearly 7 years now. And there are multiple rings, and you're going to see newer publications in this space from our group now, from here, about CT sizing, CT algorithms, effect of true balloon, etc. on mitral rings. All the rings are very different, and we made simple things so that users can actually relate to it every day. It's not too complicated or words. These are pictures I created in that paint brush, which comes free of charge on your computer. This was our go-to thing. I had actually one great experience one day. I was flying from Irvine or somewhere, I can't even remember. It was a long flight. And British Airways has this herringbone kind of seating in business class. Like you sit opposite the next guy, they can see you through that window. And I was drawing something and all, and this woman was sitting there, and she said, can I ask you something? Are you a designer? I said, no, I'm just not at all. I'm a doctor, and this and that. And she was actually the head designer of Gucci in Europe. And it was a very interesting conversation for the whole journey. And she said, oh, you're constantly drawing. I said, no, I'm just preparing my presentations on this silly program called Paint and Brush. LVOTO, we again think a lot, and this again, we had a case which was a live case done in London, and 3-4 months later we had to reoperate. And we realized that this is something wrong because we had never seen this before. So we investigated it as usual. I remember Martin Thomas was walking past and I said, Martin, I've got this bracelet. So he was used to that. So, okay, what's the crazy idea now? I said, don't you think this is aortomitral angle actually? If it's less obtuse, it's going to cause problem. He said, let's look at it. So we looked at echoes and everything, and we came up with a very simple thing. And again, we didn't have sophisticated software that time. But we realized that if AMA angle is less than 115, there's a really high chance of LVOT obstruction. This was a very simple, test you could screen from 2D echo. And of course, large septal bulge, if it's a pericardial valve, small ventricle added to it. But this was a good starting point, and I firmly still believe this is a great starting point in centers who don't have access. We teach fellows who go to, Jonathan is in Panama, or Oliver is in Mexico somewhere. They don't have access to softwares. We teach them these things and they work in practice because they're basic, but they do work. So we did huge amount of work. Our anatomy department in Guy's St. Thomas is amazing. So I used to go and teach them there. So we got cadaver hearts from United States because we can't get them in UK. And we did a lot of work in cadaver hearts on orientations of valves, effect on LVOT, and etc. And this got published as well around that time. This was followed by Jonathan and of course, Philip Blanquet's publication on neo-LVOT. So today, a lot of this information is there in the app. The apps are downloaded everywhere. People use it and they're free. So we are really happy that this is a growing, field. And again, now we're going to float these apps soon from MHIF. We did some really cool cases. This is a pregnant lady on ventilator in pulmonary edema in Oman. We are doing a double valve in valve, and happy to say that she delivered, 3 weeks, 4 weeks later. And the baby is doing well. This wouldn't have been possible if we didn't understand the nitty-gritties of it. And something very strange happened in this case is we did the aortic first, and then when we were doing the mitral, it got stuck on the strut. The surgeon was doing this first time in his life. They had never done a TAVR in their life. And because of legal things, I couldn't scrub, so I was just guiding them from behind. And by mistake, I used to always advance the valve in the left atrium and then unsheath it and then bring it back. But he had done that before, so it got stuck. And same idea which I showed you to cross retrograde with inflating the balloon a bit helped us. We just put 2 cc's, it deflected the valve of the strut, and we could cross. And this was like, thank God movement, and of course the case went really well. This was the double valve in Oslo, and today you would think, what am I showing here? Why are you not going transfemoral? You can see that 29 valve that time, XT, was only available on transapical system. So there was no other chance. And also we learned a lot because probably I had the largest experience that time of double valve in valves, like 2 cases that time. So one of the problems used to be if you have a tricuspid valve, your wire goes towards the apex. It's very hard to take the turn. As you can see here, we had to manage it really with the RF3 system, which has done quite well, this patient as well. We took all this knowledge to operating theater as well. This is a young kid who had operations, mechanical valve had failed. They wanted to use a tissue valve. I got called. What we did was we implanted a ring in the left atrium and then implanted a device, Sapien 3. And these are the pictures on the OR as well as, fluoro. And needless to say, this is only possible because we were working collaboratively in the lab and we were involved in TAVR. This is one of the first cases actually, and Myra was visiting us. Myra was about to start her MAC registry. She hadn't seen any cases. We said, come down anytime. So Myra flew early morning. She attended the case. And this was a case you can see, we had done transapical TAVR as well as, we were worried about LVOT, so we used a Lotus that time in this. These are the follow-up CTs after 3 years in this particular patient. We also took it to, open, TAVRs, as we call them, citral here. This is again one of the patients, just to show you really, mother of a Swiss banker, very high-risk patient. We used to do a lot of different things. We used to sometimes implant mitral rings as a scaffold. and then deploy the TAVR inside it so that the leaks and all disappeared. This was one of the techniques which has great potential, and we are going to develop it further as the time goes. And of course, pleasure to do this case with Paul at TCT. I mean, this is the open mitral valve in valve. Again, a collaboration between imaging, surgeon, cardiology, and the whole team that we can actually get this technology in the OR as well. One of the great things about all this has been friendships. And we used to fun way called it CSI, this series that started, and it's like, what went wrong? And can we learn from this? And a lot of this was through, phone calls, communications, getting a call suddenly when you're driving and stuck somewhere saying, we have got a stuck valve in aorta, Vinny, do you have any trick down your sleeve? Things like that. And this is, I showed you that case where valve had embolized, and this is one of my mentors in another center north of England. And he said, Vinny, something went wrong. And I told him as soon as I saw it that you were stuck in the mitral chordae. The wire had gone from apex through the cords into the aorta. And actually, they had not paid attention to, you can see the TE probe, but the person doing TE probe was not there at that point. And we used to train people to always say that when you pass the wire, you have to see it under live TE going into the aorta. So these were simple mistakes, really. This was not something easy to learn and apply in your practice. And I told you, gets the privilege of cool cases as well. This is a dextrocardia and TAVR. Now, how many times you see that? And this was a case, I did with one of the teams in South Africa. And then finally, I can show you, this is a case I showed you 40 plus years of a Star Edward, and we are doing now a TAVR device. So the design changes have really helped these patients. This is an extremely old patient. And then we didn't want to do another open surgery, so we implanted a LVOTO in this patient. This is quite nice, you have a Edwards mechanical and a Medtronic LVOTO in this particular patient. But it just goes to show whatever we do, there are many things, and I'm just going to skip through a few of them because of time. But this was my first case in the United States, patient with a 5 centimeter IVC. We didn't know what to do in this patient. He's in hepatic coma, etc., big liver. So what we did was we did a small chest opening. We went around the IVC. We put a mitral ring 32 size around it, sutured it, we cut it, put it around, sutured it back, put 2 sutures on the diaphragm, and then we implanted a Sapien 29 in it, transfemoral. This patient lived for 2 years plus, and then finally he died. Every time he used to go to follow up, one of the doctors said, they never did do anything to your tricuspid valve. I think they told you lies. But this was a fact that he really improved on table and later at least a good quality of life for 2 years. TMVR technology, we started in 2014 with Fortis. This was actually the second implant ever. Cardiac Q was done in Copenhagen that time, transapical. And then this was the Fortis device. And then in 2015, we started with the Intrepid. That time it was called 12. And then as I moved to Columbia, we did a lot of Navigate tricuspids, and following that Intrepid tricuspid as well, and Evoke. One of the tragedies of my life, sometimes I say in a fun way, is that surgeons think I'm a cardiologist and cardiologists think I'm a surgeon. So it's a difficult balance at times. 90% of my operative work actually is open heart surgery, and I love it. But 90% of my research and passion is all transcatheter world. So it's a difficult balance, but it has impacted my practice. John knows here, and Joao knows very well that I do incorporate, imaging. I learn a lot from them, and that gives me a great insight into what I'm doing to my patients. Pre-planning is going to be critical. This has been a long message for nearly 6 years. Use CT in aortic valve replacement. Surgeons were just not, they're like, why? And now it has become, I think, a gold standard. And Isaac George, who's my friend and colleague from Columbia, has published a lot on this as well. Team building has been important. Work in isolation is never good. Working in team is really, really critical. As you can see, most of the places I have worked, great teams. Of course, sometimes you get things wrong. But most of the times you'll get it right because there are more than 2 or 3 pair of eyes watching everything. We incorporated this in our practice. We had patients who were too sick to undergo a full open heart surgery. For example, Francesco was my trainee. He said, why don't we do PCI and mini AVR? And we did a great amount of strategy. And you can see by 2013, St. Thomas's was an extremely mature center. We didn't do contrast CTs that time, but we were really mature in terms of how to handle our flow for patients with aortic valve disease. Concept of lifetime management, finally, I think this is becoming really important now. And the next challenges to all of us is this. As you know, the Inspiris valve is what we implant here today. The valve size marker is my idea, and this is IP, St. Thomas's now, loans it to Edwards. Slowly, I think this will be incorporated in many other ways. There are some future ideas as well we are discussing at present on modification of all these expansion features. We know that transcatheter word is great, but sometimes things go wrong. I do get called now and then from many, in fact, how to explant these valves. We have started now international registries to show what the results could be. Are we improving with them? And a lot of focus now on, doing teaching videos on how to explant it and convert it into a more simpler operation. So all these efforts are currently what I occupy a lot of my time on. Sequencing is a word you will hear more and more, and this is essentially lifetime management. And now you're seeing that we have so many different options. We need to be careful about how we choose and what. So building evidence for this is going to be really critical, and I think our center here is in a good place to do that because we have close community, we work as a team, and we have good follow-up of our patients. Some fun facts. This is just British Airways snapshot a few years ago. I have traveled now nearly 2 million miles. I have traveled all over most continents except Antarctica. They don't do TAVRs in Antarctica. I have had the dubious distinction of training the northernmost cardiac center called Tromsø. You can see it's actually in Arctic Circle. And the southernmost center, Dunedin, in New Zealand as well. Lot of friendships, of course, from Saudi Arabia to New Zealand to Russia to everything. Great, means it's tiring, but it has been really great. Some things change, some things don't. This is my picture in Toronto, and in 2014 I went back. Nothing has changed except hair on my head, maybe. Not maybe, definitely. But I went and took a picture. Charlie Peniston, who was my trainer that time, came and actually obliged, and he said, Vinny, you have to take a picture here. I said, okay. Lost in translation, traveling all over the world, different languages. They always say I'm an honorary citizen of Poland and Czech Republic. I have trained most of the centers there, and they really like me. But this is in Russia with two Alexanders next to me. Both could hardly speak English. And you can imagine the fun and chaos and things used to happen, miscommunications more so. But the most embarrassing moment in my life has been this. Late night checking in a hotel in Gdansk, which is a city in Poland. And the hospital and the Edwards team said, you're coming really late, so we're going to leave a message at what time we meet in the morning. So I go there and I ask this girl, I said, do you have a message for me? And she was just like, she blushed and everything. She's like, massage at this time? So I realized that I think, people need to watch more Indian movies if they want to communicate with me. Tale of Two Cities, of course, Marty has always been my mentor, but Sushil and Matt are really close friends. And finally, I think this has been my philosophy, is always look at things differently. Because there's more to learn. There's more to learn from everyone. Trainees have taught me a lot of things. And I think this is the most fundamental thing in my life. I'm going to close with a funny video. I used to give a talk in Edwards Proctor meeting. And when I say Proctor meeting, there used to be 10 of us sitting around a chair, beating our head, like, how can we improve things? And the second time, it was slightly larger group. So Edwards said, all the clinical specialists, who I learned TAVR from, really asked me, Vinny, can you give this talk? We want you to give this talk. And I used to call this TAVR Travels. I made it into TAVR Travels. So he said, okay, let's make some fun video. And a lot of us have grown up seeing Star Trek, correct? So, And actually, whatever it says here applies to that. So I'm just going to play this video.
Space, a final frontier. These are the voyages of the starship Enterprise. Its 5-year mission: to explore strange new worlds, to seek out new life and new civilizations, to boldly go where no man has gone before.
So this I still feel was the great theme. The tower feels like, where no man had gone before. And I think where we have reached today is just fascinating, and there's more to do. Thank you.
Thank you. Any questions, anyone in the audience?
Vinny, fantastic. Are you just a unique individual, which you are, or is there a way to identify other surgeons who can understand imaging, do transcatheter procedures? Is this an ongoing process for other people?
Yeah, that's a very good question. I think some of us, my generation, have survived, I would say. Most young surgeons have a hesitation. Transcatheter valve, everybody feels, has become so cardiology based now. Is it worth involving your time in it? And I always give them an advice that the way you can impact this whole therapy area is if you understand it. And if you understand it fully, then only you can impact your practice. I think that's very important because we are going into an era of more complex practice now. TAVRs become class 1 indication. So a lot of these patients will come back. Now, if people don't know about TAVR, how are they going to explant it, for example? Or when are they going to, choose between one therapy versus other? So young surgeons are still involved. Like in Colombia, as you know, there's a surgical fellowship for TAVR. But these are few now, and we do encourage people to get involved in it. Imaging, I think, is really critical. In fact, the TMVR imaging session, there were young surgeons who had attended as well. That's an encouraging sign. We always show people why imaging is critical. And I think imaging, advanced imaging as we call it, I think is going to become, like it became in congenital heart disease, I think it's going to become a necessity more than luxury. So Thomas Modine, as you know, is one of my close friends in France, or Vinu Turani, who's here. There are few, Isaac, there are few surgeons, but hopefully there are more now from younger generation.
You must not sleep. That would be my first observation. And that was a wonderful talk. Could you just give us a perspective of how the U.S. differs from the U.K. and management, let's say, of aortic valve stenosis?
Right. So, it was interesting because when the trial started, we were far ahead in the curve than United States because you were hampered by results of partner. You couldn't do much. In Europe, it became much more liberal. The only bottleneck was cost, to be honest, because it's expensive technology. And that remains the bottleneck in United Kingdom for sure even today. So most centers had a remit of 40 cases per year. That's it. And St. Thomas's was the only place where we could do more because our charity supported it. Barts and London Chest is another center which was a large volume, and Brompton, where Neil Mort used to work, was slightly higher volume. But the main bottleneck was always the cost. It was never indication. So we were actually one of the first ones to expand indication. For example, patients with patent grafts do TAVR. That again, I proudly say it came from St. Thomas's again. See, we analyzed our data properly, and we showed that if a patient is 70 plus who already has CABG, patent grafts, we should think of TAVR more than redo open surgery because life expectancy, complexity, mortality, everything. So I think currently in UK, Germany was flying. If you look at even today, but that time it was glaring, because if you look at the pie chart, Germany was 70% market in Europe, then France, and then others were scattered here, there. And that became maybe 60% was Germany and 40% rest of the Europe. And that remains even today. Means Holland has 10 cardiac centers, only 5 were allowed to do TAVR. And each had probably 20 or 30 cases assigned per year. So, we learned whom to do it and whom not to do it very fast, because we had to use our resources properly. But if you ask me, another interesting thing we looked at is our first 10 patients, how many of them I would do TAVR today? I would say probably 2. Means the fit exercise was, can you raise your hands like this? Oh, she's fit to have TAVR. Because we were told that these are really inoperable, that kind of patients. So we learned a lot. We burnt our fingers many times, but we were bold enough to address it and apply that and move ahead.
One online question thus far, and this question is, you briefly mentioned sequencing of valve implantation. Can you touch on how this is changing now with valve-in-valve with respect to a younger patient who may need multiple aortic valves in their lifetime, provided all options are available?
Yeah. I mean, that's a great question. And as I said, this is going to evolve. When Todd Dewey, who is a surgeon in Texas, we were discussing, he came with the idea like, why don't we do TAVR in patients who are pregnant? Give them few years and you can always operate them later, which we did actually systematically, especially with Medtronic. But the whole idea of, can you do a TAVR and then explant it and then do surgery? So the sequencing, essentially in my mind, what it means is, if we can do one surgery or no surgery without changing the life expectancy of the patient, I think that's going to be important. So whether we do TAVR first and explant it and do SAVR and then valve-in-valve, or we do TAVR and TAVR in TAVR, or we do SAVR with longer durability like Inspiris claims to have, and then do just one-time valve-in-valve. A lot of this we have to wait patiently, because the early data on both sides is more confusing in terms of midterm application and long-term application. So I think we are going to get wiser soon. And I can tell you that now itself, that TAVR explants, for example, the early mortality was pretty high. But now as we are training and teaching people, techniques of safe explant, the surgeries are getting compact, simpler. They're kind of resembling aortic valve replacement first time. So I think that's going to define where it sits as well in the algorithm. So I think a lot to learn still in the sequencing part of it.
Vinny, do you think the sequencing has to do with matching the strategy to the longevity of the patient?
Absolutely. I think it's easier to put people in silos of, age 60, 65, 70, 75. But we also we have to understand what's the longevity of those patients. A 60-year-old with a longevity of 20 years is different than a 60-year-old with longevity of 8 years or 5 years. So these are the really complex algorithms, and we are never going to have a trial in this. This is only going to be led by practices like Copenhagen, for example, or here, where you have good data, good handle on what we do and why we do it, and keep following, long-term or at least mid-term to 5 years and see, are we doing the right thing? And then this is going to impact, I think, our decision-making.
Thank you very much.
Thank you.